Um, Somebody was telling me yesterday, in a class, and the trainer said, well, the most important holiday of the year is tomorrow, which is today, is Father's Day. So happy Father's Day to all the fathers here. But in reality, I know it's the 20th most important holiday of the year. We know our place, so we're just happy that there is a day in a year for us. So these are the objectives of my talk. I'm going to keep watching the time. I added several slides to provide you flavor as to what's going on in the field, but I will finish on time. So I may skip some that I think are maybe less useful, but we can do anything in the panel. Most important thing, I think, from an update from last year is that there was a change in nomenclature that happened in December. So we don't call non-alcoholic fatty liver disease by that name. It's called Metabolic Dysfunction-Associated Steatohepatitis liver disease. Anyone who had fatty liver is classified as having steatotic liver disease. And then within that, we've got broad categories. The most common is still MASLD, which used to be called NAFLD. And then we have people who drink excessively, alcohol-associated liver disease. And then there's an entity in between that we're trying to, further identify and recognize. We think it's important, but majority of us don't know how to find that. And we'll discuss that a little bit, maybe in Q&A, that we call combined MASLD and alcohol-associated liver disease, which means you've got metabolic syndrome traits, but you don't drink to the extent that will classify you as alcohol-associated liver disease, but it's not minimal alcohol either. So I think this is a category where many of the gastroenterologists fit into, and that's why we're trying to understand it a little bit better as to what exactly it is and how bad can it get for us. So really important to have a handle on this particular category. And then you've got people who have monogenic disorders, genetic diseases, and this is another area of our interest, and I think more and more work will be done. If you have somebody who has normal weight and they still have stage 3 fibrosis and they don't have type 2 diabetes, then we need to think about maybe something else is going on in them. It's not uncommon. It's probably 1 in 50 patients that we would see in our practice. But when we are routinely seeing our patients, you sometimes tend to miss. We can discuss that as well. And then cryptogenic is we can't identify any other cause that's cryptogenic because it's becoming less and less now. 90% of our steatotic liver disease remains as MASLD. Globally, we think about 1 in 4 individuals have it. There's a clear ethnic predisposition. Asian Indians are more likely to have than Hispanics. That's why it's really important in Southern California, and that's why we are studying it. Risk factors include metabolic syndrome, such as obesity, hypertension, hypertriglyceridemia, insulin resistance, type 2 diabetes. There are at least 3 genotypes that are important that increase the risk for NASH, which is a PNPLA3, TM6SF2, MBOT7. We are now developing treatment to silence many of these genes to treat NASH, and hopefully next year we'll have either next year or following year we'll have phase 2b data from these studies. Then we have HSD17B13 that's protective. And so you may have seen in your practice there are individuals who drink excessively or they have significant metabolic risk factor. And you examine, they don't have any fibrosis, they don't have steatohepatitis. Who are these people? They may be protected because of HSD17B13. It's about 5 to 7% of the population. And so we're harnessing that as a treatment. And then, defining a problem is really important. So this is the definition that we use. MASLD is diagnosed either on biopsy or imaging, evidence of hepatic steatosis in individuals with at least 1 metabolic risk factor. That's the new addition, who consume little or no alcohol, and there's no secondary cause for liver disease or hepatic steatosis. So that's the new definition now for MASLD. This is just to have a lexicon in terms of terminologies. NASH is now called MASH. NAFL is now MASL. At-risk MASH is somebody with 2-stage of fibrosis and presence of MASH, which is the group of people who require pharmacologic therapy. Recent data suggests that MASLD and NAFLD have a 95% overlap. So we can use these terms synonymously, and there's no change in regulatory pathway for clinical drug development. I'm going to skip some of these slides so we can get to, this is important. So we're determining how much reduction in liver fat is clinically meaningful. And that's important because if you look at about all the therapies that are currently in phase 3, where we are thinking they may have positive data, all reduce liver fat. And the first 3 trials using MRI-PDFF were done at UCSD 10 years ago. And at that time, there was a lot of concern that what does the meaning of liver fat reduction and would it actually translate into histologic benefit? So clearly, there is a straight correlation now. If you achieve the 30% MRI-PDFF response rule, you have 5 times higher odds of NASH resolution. And that's really true for resmetirom pathway, the drug that got FDA approval recently, but also true for semaglutide, survodutide, tirzepatide, FGF21 analogs, even true for lanifibranor, although we don't have that data. So it's becoming clear if you want to get a drug to phase 2B or phase 3, this is one biomarker that, giving you good confidence as you move towards biopsy-based study. We're trying to develop biomarkers and validate them through NIMBLE and Litmus. I serve on the steering committee for NIMBLE. We're trying to develop biomarkers to diagnose who needs to be treated and also to assess treatment response. FIB4 is important in the new pathway. It includes age, ALT, AST, and platelets. This is something we are using in our clinical practice. So if you're interested in population health assessment, then you would use your FIB4 assessment. FIB4 above 2.67, typically you want to bring those patients in to see a hepatologist. Those have below 1.3, you could wait on them. They don't have significant disease risk. Again, we are calculating the risk for advanced fibrosis. And then those who are intermediate risk probably would need another test, such as a FibroScan, ELF, or a MR elastography, depending on what test is available for your population. You could use ELF, which is Enhanced Liver Fibrosis Panel. It includes hyaluronic acid, P3NP, and TIMP1. And basically, an ELF of 9 or higher will land you somewhere in stage 2 fibrosis range. We have data on 9.8 for stage 3. You can use that as well. So if you were using that, I think it's important to know the cut points in your population that you're treating. 11.3, you get into cirrhosis domain. This is just looking at data, a question for you. In a patient who has NAFLD and bridging fibrosis today, so stage 3 patient, you have 100 of those. Not everybody's going to progress to cirrhosis. 20% will progress to cirrhosis in 2 to 3 years. Who are those? Can you identify and differentiate between the 100 stage 3 who is at high risk of progression? Single test, if you were to do, you could use ELF in that setting. And we have data that if you had ELF of 9.8 or higher, that group of patients with stage 3 are at high risk for progression. So this is how I put my tests into context of use in my practice, and this will be helpful. So don't randomly do a test just because the patient comes in. Think about it. How will you use that test? Because it'll solve a lot of problems for you and your patients, because they're going to come back and ask, it was 8.8, what do you think about that? And so knowing what you want from the test is important. And typically, I wouldn't order unless I had a plan as to, based upon this result, what we will do. And another way to think about it is, I work very closely with a nurse practitioner in my practice. And so in my note, when I'm seeing the patient, I'm going to write, if the ELF was this, then do that. If the ELF was below this, then do that. If the VCT was above that, then do that. So, the prescription for what needs to be done is clear to the patient also, because they're going to see my note anyways from Epic, but also the nurse practitioner. Makes it easier for everybody and keeps you accountable. So this is the data. It comes from 4 trials where patients who had ELF of greater than 9.8 had high risk of progression to cirrhosis over 42 months. Who to screen in terms of new data? This is one question that comes up. We prospectively assess if you have family history of NASH cirrhosis. How can you apply this in your practice? If you're a transplant center and you saw somebody for NASH cirrhosis for transplant evaluation, think of who's coming with them. They probably need a screen. If they're their offspring and they're 40 or 50-year-old, then they probably need an assessment for liver fibrosis. Risk is about 15%. Another group, this also is from a prospective study done at UCSD, where we had 100 type 2 diabetics, and we screened them with MRI, PDFF, and MRE. 14% had advanced fibrosis, those who were 50 and older. So this is now in ASLD practice guidance to screen for advanced fibrosis. We don't screen for fatty liver. We screen high-risk patients who may have high risk for advanced fibrosis. So we're screening for advanced fibrosis in this setting. This is the ASLD practice guidance algorithm. Start with the FIB-4 assessment, followed by ELF or VCT in our practice. And then anybody who has persistently elevated ALT should be seen in our practice. And then those who have a FIB-4 of 2.67 could directly come to the practice. Treatment landscape, I think the most important thing to still think about is lifestyle interventions in our patients related to because the majority are obese, overweight, or have type 2 diabetes. So reducing caloric intake and exercise is important. Weight loss is helpful, and avoiding alcohol consumption. In the new practice guidance, if you're starting somebody, say now, anybody who has stage 2 fibrosis or higher, we recommend no alcohol, which would mean that if you're starting somebody on resmetirom, you may also want to add a recommendation, avoid alcohol or minimize alcohol. The practice guidance says that if you have stage 2 or higher, no alcohol. Statin use in our patients, majority have dyslipidemia, aspirin use in diabetics, Mediterranean diet, avoid sugar and sugar-containing beverages, bariatric surgery in those who have comorbidities, type 2 diabetes, morbid obesity, obstructive sleep apnea, because that could benefit. But now with the new drugs, some of the data that I'll show you, probably less and less, and probably in 10 years, we would rarely see the surgery performed. This is the weight loss pyramid from the lifestyle interventions. You need about 10% weight loss from lifestyle to start seeing improvements in fibrosis. But it's very difficult to achieve less than 10% in 1 year in our practice. So, but now with new drugs, things have really changed. This is data on obeticholic acid, Regenerate trial, where obeticholic acid to the left was better than placebo, 23% versus 12% for one-stage improvement in fibrosis. No significant improvement in NASH resolution. This was assessed by FDA last year on May 19th, and FDA didn't feel it appropriate for clinical use in MASH, so this drug is not seeing the light for clinical use in NASH. These are some of the issues related to FXRs, and I think as a class, FXRs would have difficulty because of hepatobiliary issues related to DILI monitoring and cholestasis. These are some of the drugs that are, in phase 3 trials. Resmetirom, we have subpart H data on biopsy. It's FDA approved now. We'll discuss that, but these are the other drugs that are also in phase 2B currently, and we have phase 2B data and now in phase 3 already, and we'll discuss their data. This is looking at lanifibranor. It's just 6 months trial data. We see improvements both in NASH resolution and fibrosis improvement with the 1200 milligram dose. What's the problem with this drug is weight gain, similar to pioglitazone. Predominant effect is PPAR delta, PPAR gamma. That leads to weight gain, but we also have some PPAR alpha and delta activity. And so, this is in phase 3. We'll see the results and then see if this would be something people would consider. These are some of the issues with lanifibranor. I think it could be a drug where we're less concerned about weight gain in the setting of cirrhosis, but the cirrhosis trial hasn't started yet. But that's where I think the value might be, because what PPAR gamma does, it takes fat from the liver and then puts it in the periphery. When you stop the drug, all that fat in the periphery comes back into the liver, and actually you can accentuate the disease. So again, it's a lifelong therapy if you were to start in a patient with NASH. But you could also combine with something where you could use lower dose, combine with something that leads to weight loss, such as a GLP-1 analog. So that may happen that you can get by with a lower dose of these drugs. This is data on semaglutide, which is once daily in this particular trial versus placebo. To the left, I'm showing you data on NASH resolution that was significant over 72 weeks. To the right, fibrosis improvement wasn't significant. So we know that there are no GLP-1 receptors in the liver, and therefore the improvements that we are seeing in NASH are probably related to weight loss and are indirect. And so the idea is that you need some sort of a liver-directed therapy to start seeing improvements in liver fibrosis. But I think if you waited, say, 5 years, you will start seeing improvements in fibrosis, even through the indirect pathway. So issue with GLP-1 analogs, efficacy is NASH resolution is there, fibrosis improvement isn't there. There are GI side effects typically in the first 20 to 24 weeks. So we slowly escalate the therapy, start with 0.5, 1 milligram, 1.5, 2, 2.4 is the peak dose in NASH that we use. Majority of patients don't tolerate it in clinical practice. Most patients are on 1 milligram dose. Remedy would be combination approaches, and I'll discuss some of that data from 2B studies. So it may be used in early disease in obese and overweight patients who have NASH, maybe stage 0 or stage 1 fibrosis. People may start using this earlier for treatment of obesity or type 2 diabetes. Now you combine GIP. So all these hormones are so important because really gastroenterologists have been working on them and they are gut-derived. So we have an important role to play. I think we should also embrace obesity and insulin resistance as part of our niche and our practice. And this is something I'm interested in as to, what should be part of gastroenterology and hepatology and what we should give to other specialties. It's really important to bring more stuff in rather than letting it bleed to other areas in medicine. Tirzepatide is a drug that has both GIP and GLP-1 efficacy. What you get from GIP, in addition to what you are getting from GLP analogs, is you might have an increase in glucagon. The other action is peripheral action, which is in adipocyte. It can improve peripheral insulin resistance, so that can potentially benefit steatohepatitis. And now the trial, we had top-line data that we presented at EASL, and I'll show that to you. If you add a glucagon receptor agonism on top of GIP and GLP analogs, then there's a new drug that Lilly is developing called retatrutide. You can get about 20 to 25% weight loss in 1 year. And we have data on liver fat reductions in those. I'm not showing you that, but I'll give you the rationale of why glucagon agonism would be important. So glucagon is liver-centric, as we all know, and you've seen patients, although rare, with glucagenomas. And those patients really present with this extreme manifestation. But if you titrate it and use it for pharmacology, this could be beneficial. But by itself, it'll be bad for our patients. Why? Because it increases glucose levels. So it causes neoglucogenesis from the liver and basically converts anything that's stored in the liver into glucose. But when you have GLP-1 analogs in association with glucagon agonism, you can take care of that. And that's the benefit of dual therapy. So it's going to burn glycogen. It's going to burn liver fat into glucose. So there's a pathway to, get rid of fat from the liver. So when you combine, say, a glucagon agonist on top of GLP-1, you have a net 2 to 3% additional liver fat reductions, and relative reductions maybe 10 to 20% more. So this is the glucagon pleiotropic effects in the body. You can see the liver section is so deep, and that's really important. Also leads to ketone body production. Why is that important? Most NASH patients, even if you draw their blood 12 hours after fasting, when you study them metabolically, it feels as if they are in fed state. They're never in fasting state. So there's this hormone that'll put our patients into fasting state. Because fasting is important to increase beta oxidation. If you don't achieve that fasting stage, you don't get into beta oxidation. And that's why it's important to harness the effects of glucagon. This is a trial using pegozafermin, FGF21 last year that we presented. This showed improvements to the left on fibrosis, 20% treatment effect delta, and to the right on NASH resolution. There are two FGF21 analogs that are now in phase 3. Pegozafermin is a glycopegylated version of that. It could be used once weekly or twice weekly. Again, the main side effects with FGF21 class are diarrhea and GI side effects. Of course, you can get some injection site reaction, but those are the key effects. You don't lose weight, but it increases your appetite. And we can discuss during our panel discussion, but many of these drugs may also modify your craving for alcohol. And that's becoming more and more important, and you'll see that data coming out next year. And that's why I'm getting interested in now treatment of Met ALD as well. This is data on resmetirom. This is now FDA approved. It's a thyroid hormone beta receptor agonist, 100 milligram versus 80 milligram versus placebo. We had a baseline MRI, PDFF, and a biopsy, and a 12-month biopsy. The trial is still ongoing. We had these two primary endpoints to look at both NASH resolution and fibrosis improvement. So oral drug once daily. And you can see we had significant improvement both in fibrosis, but also in NASH resolution. And we are using that in our clinic now. We have set up a separate resmetirom treatment clinic, and we have patients who are currently on therapy with resmetirom. Again, main side effects that we see typically are diarrhea or GI side effects, but other than that, usually not a problem. Typically, it's indicated for patients who have moderate to advanced fibrosis without cirrhosis. So we're trying to identify these individuals non-invasively, and I've put in some criteria that we're using currently in our clinic. I have to have some evidence of hepatic steatosis. In our setting, patients are getting a free MRI, PDFF, and MRE before they start, and we're going to repeat that at 1 year. But we are using either FibroScan for eligibility, ELF, or MR elastography. And then if you have CAP for hepatic steatosis assessment, you could use 280 decibels or higher for inclusion into this non-invasive algorithm. And there will be more, there will be 2 expert panel papers and then an update from ASLD that'll be coming out, so how you can identify these patients non-invasively. From EASL, we had data from Ionis on a DGAT2 ASO. So this is an enzyme that's really important for fatty acid synthesis in liver. And if you block this enzyme or silence this gene, you could improve hepatic steatosis and lipotoxicity. And so this is a drug, this is a company based in Carlsbad, where we are right now. You can see we had improvements in NAS, NASH resolution, and fibrosis as well. This is looking at the other FGF21 analog, efruxifermin, which is once a week with 28 milligram and the 50 milligram, and we have 96-week data. You can see fibrosis improvement up to 75% over 2 years, and you can also see improvements by 2-stage. So this is helpful as we are accumulating data on many drugs, and continued treatment will lead to further fibrosis response. This is data on survodutide, which is a glucagon plus GLP analog developed by Boehringer Ingelheim. This was presented at EASL, where you have significant improvements with the 3-dose compared to placebo for NASH resolution. Fibrosis improvement, if you look at the bottom slide, that's the intention to treat analysis. You see numerically higher, but again, I think the sample size is small. Also, the side effect rate is high with the 6 milligram dose. About 20–25% of patients did not continue this treatment. So probably the dose might be somewhere between 2.4 to 4.8 milligrams. This is Fascinate-2B, which is a FASN inhibitor that we showed, again, a phase 2B data that was positive here for both NASH resolution, 2-point improvement in NAFLD activity score, and also on fibrosis. This is data on tirzepatide, which is a GIP plus GLP analog. And what we showed here was there was significant improvement in MASH resolution to the left, and also fibrosis improvement to the right, also presented at EASL and just published in NEJM. So in summary, MASLD is the new term replacing NAFLD, MASH replacing NASH, essentially no impact on regulatory pathway, and non-invasive risk stratification is taking the center stage. Resmetirom is approved for treatment of NASH and NASH-related fibrosis, and several cluster of drugs are showing promise in the treatment of NASH. So this is really exciting this year as we have a drug approved in clinic and also several drugs that are in pipeline showing positive results. Thank you.